Hi, everyone. My name is Adam Suleiman, and I'm a second year internal medicine resident here at U of T. I'm very excited to share with you today our case entitled A Subtle Presentation of an Aggressive Disease. This case highlights a 65-year-old man who presented with weakness and difficulty coping at home to the emergency department. He had a past medical history of COPD, BPH, GERD, and major depressive disorder. He lived in supportive housing, but did not regularly have routine medical care and had a 42-pack year smoking history. His history started about a week prior to when we saw him, when he had recently been admitted for an acute kidney injury that resolved with intravenous fluids. He represented after describing ongoing weakness as well as quite profuse sweating at home as the result of a malfunctioning radiator in his building. This was causing very high temperatures, and he was not leaving his home due to concerns with the COVID-19 pandemic, resulting in minimal access to food and minimal oral intake. On exam, he was afebrile, although mildly tachycardic with a normal blood pressure. His cardiac and respiratory exams were unremarkable, and he had no palpable lymphadenopathy or organomegaly. Initially, when he presented to us, his hemoglobin was 110, his platelets of 81, and his white blood cell count at 12.3, with a relatively unremarkable differential. Throughout his time during his hospital admission, we repeated some blood work as the patient was noticed to have intermittent low-grade fevers in hospital. 12 days after, this showed a new hemoglobin of 83 with a white blood cell count of 17.8. And interestingly, his monocyte count had increased to 9.7. His LDH was also greater than 1900. And as part of the work of a CT scan of the thorax revealed extensive abnormal lymphadenopathy consistent with a lymphoproliferative disorder. Later on bone marrow biopsy and on core biopsy, this did confirm a high-grade lymphoma. What's important to highlight here are the causes of monocytosis, and specifically thinking about the differential diagnosis. It's important to recognize that monocytosis may be reactive in a variety of conditions, also in things like classical Hodgkin's lymphoma, but may itself be an indication of malignancy, such as in chronic myelomonocytic leukemia, in which case the monocytes may be particularly elevated as that's the primary disturbance. However, in other myeloid or lymphoid malignancies, this is also seen. The other important part to highlight is that in marginalized populations, we know that there are significant delays in diagnosis for solid tumors and poorer prognoses with patients with non-Hodgkin's lymphoma who have low socioeconomic status. All of this put together, we really wanted to highlight that the presentation of lymphoma may be very subtle, and retrospectively, a patient may be describing B symptoms. It's extremely important to recognize this, especially in a patient who is otherwise marginalized and not well connected with the healthcare system. And recognizing these subtle presentations may help with the diagnoses of these aggressive diseases. Thank you very much for paying attention to this presentation.